Hello, everyone, and welcome to the Toronto General and Western Hospital Foundation COVID-19 virtual Q&A. We hope you are staying safe and taking care of each other during the pandemic. My name is Christian Coté. I'm host of the UHN podcast, Behind the Breakthrough, and we're glad you could join us and grateful to you, our family of supporters who've been so generous throughout this challenging time. So a big thank you on behalf of the foundation and all of UHN. This episode, we're talking about vaccine rollout, the virus spread, and we'll reflect on the one-year anniversary of the World Health Organization declaring a pandemic. Plus, we'll be taking your questions later in the program. With us today, we're so pleased to be joined again by Dr. Isaac Bogoch, a UHN staff physician in the divisions of internal medicine and infectious diseases, and a member of Ontario's COVID-19 vaccine distribution task force. Welcome, Dr. Bogoch.
Thank you so much. Good to see you again.
You as well. Okay, so let's dive into the pandemic anniversary today. It's been a tough year for everyone, and especially so for healthcare workers such as yourself. Talk to us about the impact of this past year that it's had on you and your colleagues at UHN.
Oh, yeah. It's been a tough year. That's putting it lightly. It's been a very challenging year. Obviously, I can't put words into the mouths of everyone who works at UHN. I'm not going to pretend to speak on behalf of all the healthcare providers. But I think it's safe to say that people are exhausted. People are at their wits' end. People have been going like stink for over a year now. Everyone can't wait till this is done. It's interesting too, because when you think of a hospital environment, obviously we're thinking about doctors and nurses and other frontline healthcare staff like the physiotherapists and occupational therapists and pharmacists, speech language pathologists, dietitians. I could go on and on and on. There's a lot of frontline staff. But there's a lot of non-patient facing staff as well that truly are exhausted as well. Like there's, the laboratory technicians. There are people in shipping and receiving. There's the people who are cleaning the hospital, like the porters. This has an impact on everybody under that roof. COVID-19 makes everything more challenging, makes everything harder, makes things less efficient. So I think it's safe to say that patient facing or not, we're done. Everyone's done with this, but of course, we're not really done with it. We're on the home stretch, and it's been tough. But I think this late spring, early summer, we might be in a lot better shape.
Fingers crossed. But look, I talk to doctors, throughout the week for stories that we do for UHN News, and I hear from some of them, we signed up for this, but you're probably no surprise to you. The Canadian Medical Association today just released a survey documenting over 60% of members feeling fatigued and anxious because of the pandemic. I know many of you working in healthcare talk about always sort of being on high alert. And when you go home, because of the fear that you're bringing the virus home as well. So I'm curious how you navigate this constant state of, say, hypervigilance.
Yeah, it's amazing how you just adapt over time. Like we've been doing this for over a year now, and it just seems normal when it probably shouldn't feel normal. And I mean, I remember earlier on in the pandemic, maybe it's too much information. You do your best. You put on your mask, you put on your gloves, you put on your face shield, your gown, you do everything you can. But listen, you can't be perfect 100% of the time. And I had an exposure here and an exposure there. And, obviously, no one wants to get COVID-19. I remember thinking it wasn't a major exposure, but it was still an exposure. I remember going home and telling my wife, like, honey, this happened. You want me to sleep in the basement for 2 weeks? And the answer was, wasn't a big exposure. We're probably okay. So I think a lot of it, too. I mean, many of us have wonderful partners and wonderful support networks. And I think that's just been extraordinarily helpful for me, for sure, and of course for many others. So it's very helpful to have a team backing you up.
Exactly. One of your teammates, I don't know if you know Dr. Don Lim, an emergency physician, wrote a really poignant essay for UHN News recently, and she said, in terms of the impact of the pandemic, at one point in the essay she wrote, "I am not unscathed from COVID." Does that resonate at all for you?
Oh yeah, I don't think anyone's unscathed. We've all had an event or multiple events, or just the chronic gnawing of this pandemic at our sides. So yeah, no one's going to come out of this unscathed. Everybody is, some more than others. But Yeah, I mean, it's certainly been tough, and it's not just from terrible events that happen in the hospital, right? It's not from the umpteenth Zoom death or something like that. It's everything else, right? It's just the chronic nature of the virus, and that you're just dealing with restrictions, and every aspect of your day is impacted by this virus. You have to put out your mask is on every second of the day. You're gowning and gloving all the time. Like, it's just everything is harder. There's nowhere to sit and have lunch. Like, everything is inconvenient. There's no easy ride. Everything is inconvenient. And then if you sort of fast forward a year, yeah, it kind of adds up. So I think it's fair to say that no one's getting out of this unscathed.
Well, listen, we're grateful to you and all your colleagues who do an amazing job every day at UHN. So thank you. Okay, let's turn to vaccine rollout. Last week, you know very well, a controversial decision to extend the interval of the 2-dose vaccines to 4 months. So, and my understanding is that recommendation is based on an extrapolation. There's no data yet on the effectiveness of the 2 doses with that length of time in between. What's your take on this?
Couple of things. If we were having this conversation in December, the debate was, can we delay the second dose? And that was, under heated debate. Now it's pretty clear. There's definitely emerging data that says, yeah, you can delay the second dose. The debate now is, okay, how far can you delay the second dose? I think people could confidently look you in the eye and say, we have decent data to suggest we can delay the second dose at 2 months. We can delay the second dose to 3 months. Yep, it's delayed to 4 months. And of course, we've heard from NACI, the National Advisory Council on Immunizations, saying that they think you can delay this up to 4 months. I don't know what the data is that they've used to suggest the delay between month 3 and month 4. On the other hand, too, I don't think it's a terrible suggestion. I think it's likely to be okay. But if I was presenting this nationally, I'd have a lot more confidence to say, you know what, here's the data for 2 months, here's the data for 3 months. So obviously, if you're going to make a major policy, it is helpful to have a spokesperson from that organization stand up and say, yep, this is how we came to our conclusions. So I think, the communications piece would go a long, long way with this, and especially if you want more public trust and public buy-in for a decision like that. Still, I mean, when you think of multiple dose vaccines, we space them out all the time. Life happens. People miss their dose or delay the dose, and we vaccinate, and there's just no issue. So, I'm not saying that there won't be any issue with 4 months. I'm just saying that we have much better data for 2 months and 3 month delays.
Well, and you know very well, you're highly read on this subject. There's been vigorous discussion, disagreements. Some in the medical community say this is a population experiment. What do you make of that concern?
Well, I wouldn't say some. I'd say one person said that. That just happened to be a very senior person, and that news clip was repeated over and over and over and over again, so that we've all heard it. Now, I wouldn't go that far to say it's a population level experiment, because it isn't. I would say that certainly we have data to suggest that 2 months is okay. We have data to suggest that 3 months is okay. And, it's not outlandish to think that a 4 month delay is okay. If I was making that decision, which I'm not, I would get up in front of the people that I was deciding for and explain how I came to that conclusion. So it's not just the answer that's important, it's how you got to that answer that's important, and also how you communicate that is what's important as well. It's like a grade 10 math problem. Like, you can't just get the right answer, you got to show your work, and in all fairness, I don't think NACI really showed their work. They explained why the 4 month delay would be helpful from a public health standpoint, right? We get it, but they didn't explain how they got that result. And it would be helpful to have more clarification. Again, I don't think I'm trying to be careful with my words. I don't think it's going to be a problem, but again, it would be helpful for a representative from NACI to explain how they got to that.
Exactly. Yeah. I think for many of us, it's also confusing, right? Because the previous delays that came up were because vaccine supply was delayed, but vaccine supply does not appear to be an issue anymore. So I guess some of us just are kind of puzzled, like what's in terms of the timing. Say why now?
Yeah, I have the same questions.
All right.
I'm not, so let's be clear. I'm not defending them at all. It'd be nice to have them communicate and have a Q&A with representatives from them. I'm not on NACI. I didn't make that decision. I think it would be. I have similar questions as many other people. In the same breath, though, listen. I mean, we delay vaccines all the time, multiple dose vaccines all the time. We know that there's very, very good protection following one dose of a vaccine. A delay of 2 months, a delay of 3 months, and probably a delay of 4 months is okay. Keyword, right. Probably.
Look, I don't mean to put you on the spot. We appreciate.
Please put me on the spot.
We appreciate your insights, and the hope is, of course, that we don't get to that 4 month gap. That we can actually administer vaccines before that period. Okay, so we have 4 vaccines on the market now, and with the approval of the Johnson & Johnson single shot. I'm already reading that some people are saying they don't want the Johnson & Johnson vaccine because they don't, they're reading the same literature, I guess, as all of us in the media, that it's not as effective, say, as the Pfizer or Moderna vaccine. Do people have reason to be concerned?
So I think when we're talking about the vaccine efficacy, many people are looking at the clinical trials and they see numbers like Moderna and Pfizer, efficacy of 94%, and they see some of the Johnson & Johnson, Novavax, AstraZeneca, they're seeing things like in the 60s and 70%. And they think, whoa, one's way better than the other.
Exactly.
We have to sort of think about this a little bit more carefully. The Moderna and the Pfizer vaccines were tested in an era where there were very, very few variants of concern circulating. The other ones were tested in an era where there were a lot of variants of concern circulating. So that difference is probably a lot smaller. That playing field is probably a lot more level than what those numbers suggest. The other important point to remember too is, sure, at the end of the day, there might be some vaccines that are more effective than others. That might be true. That really might be true. Okay, then you have to put this into the current context. We're in a public health crisis. This is a public health emergency. It is. There's no other way to put it. 22,000 dead Canadians. Thousands of new infections per day. We're sitting on the cusp of a third wave, or hopefully a wavelet. And we have currently 4 approved vaccines, 3 of which we have in the country. And guess what? All of them significantly reduce your risk of getting a serious infection and dying. All of them do that. So the answer right this minute is, you should stop. If you have an opportunity to prevent yourself from getting sick and dying, you should take that opportunity. So any of the vaccines are fantastic at this point in time. But of course, like anything else, things change with time. There will be a point in time later on where we're all going to need a booster. We're all going to need another vaccine that accounts for some of the circulating variants of concern. It may very well be that later on, the suggestion is, you should take you're of this age, or you have these medical problems, you should take vaccine A, whereas you're of this age and these medical issues, you should take vaccine B. Currently, I don't feel that way. My bias is stop the death. All of them do that. In the months of March and April and maybe May, just take the first one that becomes available, because all of them will prevent that from happening. That's how I approach it, like from a very pragmatic medical and public health standpoint.
So let's take a minute, if we can, if you don't mind, to unpack the vaccine rollout in detail, starting at UHN. Last week, we opened up vaccination to some patients. Do you mind expanding on that for us in terms of the patients being prioritized and registering to get the shot, how that'll unfold over the next, say, few weeks?
Yeah, it's good timing, because it's going to change. So here's how it's going. Here's how it's going down. So we're still in the first phase in Ontario, and in the first phase in Ontario, the priority groups are those who live and work in long-term care, high-risk frontline healthcare providers, Indigenous communities, those who receive chronic home care, populations 80, community dwelling seniors 80 years and up, and homeless, underhoused, people experiencing homeless populations. You can vaccinate those individuals and shelters if need be. So we're still in phase 1. And there is going to be eventually a centralized provincial system to sign up for these vaccines. There's going to be an online system and a telephone system. Okay, that's probably going to be launched on the 15th of the month, maybe a day early, maybe a day late, but around that time. The public health, we got more vaccines over a shorter period of time. So the public health units already have vaccines that are available. And the public health units, 34 of them in Ontario, have said, great, we know who community dwelling elder populations are. We have vaccines. We're starting this. We're not going to wait for the centralized provincial website to go online. And kudos to them. That's the right answer. You've got vaccines, you know who to vaccinate, go for it. So public health units have taken it upon themselves to set up systems where people can sign up for vaccines. And almost every one of the public health units, probably not all, but I think almost all of them, you can sign up. In Toronto, for example, there's a centralized sign-up system, vaccineto.ca, and people can go on vaccineto.ca, and that's a centralized Toronto sign-up system for the various sites, including the UHN site. But of course, I keep losing track. It's the 11th today. All seems like Groundhog Day to me. It's the 11th today. So, stay tuned, because in the coming few days, there will be a centralized booking site. And no matter where you are in the province, you can go beep, beep, boop, because of course it's going to be that easy. And you'll be able to sign up for vaccine. And then, of course, as we move through the month, stage 1 is going to overlap with stage 2. And we'll be able to vaccinate more and more people, mainly community dwelling seniors, but of course there's other priority groups in phase 2. And it's really gonna be interesting though, because, there's still limited resources. Even though there's more vaccines, it's still a limited resource. Watch what happens as we move through March, and then right around the time March moves into April. Like, we are going to be really ticking through the priority groups. And I know we've been agonizing over who's first and who's second and which is this priority and which is that priority, but just wait. You're going to see vaccines pick up so quickly. Look at a place like Toronto, for example. I know many people are in Ontario, but a lot of us are sitting in Toronto. Toronto has 9 mass vaccine sites and a ton of other community-based sites and community centers and pharmacies that are going to be vaccinating. So of all the vaccine sites in Toronto, they estimate that they can vaccinate 400,000 people per week. 400,000 people per week if they have the supply. They can run their vaccine centers 24 hours a day, 7 days a week if they have the supply. This is going to happen, and this is going to happen quickly. So stay tuned. Obviously, we're just sitting right on that cusp, and things are going to pick up over the next 7 to 10 days.
And right now, just a small point, I understand UHN is actually vaccinating patients 80 years and older. Is that correct?
I can't look you in the eye and tell you with a straight face if the UHN is, but I can tell you if you go on torontovaccine.ca, you can sign up. And if you go on that website, you can actually see all the community-based vaccine sites listed there. And it's like a centralized sign-up tool for all of them. And of course, the UHN is on there as well.
Very useful. Okay. This week, actually, I saw the prioritizing of pregnant women for getting the vaccine, a group that wasn't included in the original trial. So there was concern over whether, they would be safe if they were to take it. What changed this week? Do you know?
Yeah, full disclosure, I'm totally biased because I'm on the vaccine distribution task force, and I'm on that subcommittee that really was tasked with creating priority populations. And I think I think it's good. I do, because you know why? It's because it's data driven and it's equity based. It's data driven and equity based. So if you focus on pregnant women, if you look at the data on pregnant women, there's a signal amongst the noise. Like, pregnant women compared to the general population and compared to age match controls, they're at risk of more severe infection compared to non-pregnant individuals that same age. They are. So a couple of things. Yes, you're spot on. Pregnant individuals were not included in those initial clinical trials. Breastfeeding people were not included in those clinical trials. Can you look someone in the eye and say, this is 100% safe? No, of course not. We just can't do that. However, since these vaccines have rolled out, two things have happened. Number one, there's registries for pregnant individuals choosing to get the vaccine. And we haven't seen any issues. There haven't been any reported issues to date. There's also registries for people who are breastfeeding as well. And now there's also prospective clinical trials that are signing up pregnant individuals too. So to date, we haven't heard of any issues with pregnancy or breastfeeding individuals. And with the knowledge, there's a few sort of points to think about here. One is that we know that this infection can be more devastating, it can be more dangerous, it can cause more severe infection in pregnant individuals. Two, it's a pandemic. Like, this infection is everywhere. Even in Canada, where we had a big second wave, and we're coming out of the second wave, we might be headed into a third wave. So, and then three, the days of paternalistic medicine hopefully are long gone. It's not my business to tell someone that they can or can't have access to this vaccine. Pregnant individuals can make informed decisions for themselves, knowing that they may be at greater risk of having a severe infection, knowing that to date we haven't seen any ill effects from the vaccine, knowing that there's still some unknown questions. We can empower individuals to make good decisions, or any decisions for themselves, to at least have informed decisions for themselves. So I like how this is worded. I like how they're included. I think it's smart.
Terrific. Okay, let's move into virus spread in Ontario. You've already hinted at the potential or possibility of a third wave. We're seeing already this week cases creep up. We're seeing the increased number of cases that are due to the variant. Is there any way, we keep asking you this, I know, but is there any way to avoid a third wave?
Yeah, you can. I don't think people want to do it, but you can avoid a third wave. So let's take all our value judgments and just put them aside, and let's just talk raw science. Okay, let's put all our political and ideologic biases aside, and let's just talk about a few scenarios. However unlikely these scenarios are, let's just talk about a few scenarios. We had a lockdown. If you made a real lockdown, I know lockdowns stink. Again, we're putting all these biases aside. If you locked down again and kept everyone at home and had stay-at-home orders and only had, for example, essential workers go to work, and if you created safer workspaces, paid sick leave, mandatory masking at work, oversight of work, ensuring good ventilation and stuff like that, you could probably, even with the circulating variants of concern, you could probably avoid a third wave. You probably could. Now, add in our value judgments. Can we afford another lockdown? Will people adhere to another lockdown? Is anyone going to actually do paid sick leave? Is anyone going to actually really work on the upstream drivers of infection and create safer workspaces and support intergenerational homes? Like, there's a lot of if in there. But even if you don't do all of that, but if you're on that end of the spectrum, you can just avoid a third wave. Another scenario is, let her rip. Long-term care is vaccinated. Those individuals account, depending on place and time, anywhere from 50 to 80% of the deaths in the country. We're good. Open her up. This is going to explode. Like, we know what happens. We've been there before. We know what happens. And then, of course, there's this massive gray area in the middle of various regional strategies, various stages of lockdown. And again, anything can happen. I think we're going to get something. Like, one of the hallmarks of pandemics is waves, okay? And a lot of this really depends on us and our behavior. And I'm not putting it on us as an individual. On us, I mean, you need significant good government leadership, good public health leadership at the provincial and local levels. And we also need population buy-in. If we're done with this, it doesn't matter what the government or public health units say. If we're having house parties with each other because we're done with this, we're going to get cases. So there really is shared responsibility. We'll probably have a bump. We'll either have a wave or a wavelet. It might look a little bit different because everyone in long-term care, or almost everyone in long-term care in the province, has at least one dose of a vaccine, and they're getting their second right now. So it might look a little different from a death standpoint. It might look a little different from a hospital capacity standpoint because vaccines are rolling out. but I don't think the pace of vaccination is as such where it would actually prevent another wave from happening. We'll probably get something. How big it is completely depends on collectively us, including leadership and policy. And we'll see. I think it's preventable and it's avoidable, but I don't think we'll avoid one.
Well, I guess is the wild card here, I guess, is the spread of the variant. And some of the reading I've done over the last week or so is we could be entering sort of the point of no return with the variants becoming the dominant number of cases per day. What's your sense of this potential over the next few weeks?
Honestly, I think variants or not, we'd still be in a very, not a similar situation, but in a sort of a similar situation. Variant or not, when you start to reopen, you're going to get cases. That's just going to happen. All the variants do is they just make it more challenging to keep this at bay. So outbreaks are a little bit bigger and it's just more easily transmittable. So variant or not, when you reopen, you give the opportunity for this virus to transmit. Obviously you have to respect the variants. I think it's just harder to keep things under control. It's interesting. Again, we got to timestamp every one of these conversations. But if we are talking this second, the emergency brake function that the province has been using has sort of maybe worked, right? Like we saw a pretty big outbreak in North Bay. Looks like they got that under control. There was concern about opening up Peel in Toronto. They delayed. Maybe things were held at bay for a while till we could vaccinate a bit more. Sudbury's going into lockdown now because of a high case number. We'll see if that works. Thunder Bay is taken off. That's unfortunate. Maybe they'll get that under control. Like, again, I don't have a crystal ball. I don't have a ton of confidence either that we're going to avoid a third wave. I think we're going to get something there. I just don't know how big it's going to be. And I'm partially comforted that however big it is, it still can cause harm, but at least people in long-term care are vaccinated.
Fair enough. So the big picture, it just feels like we're on this collision course, like we're a race, get the vaccine into as many arms as possible versus the virus spreading again.
Yeah.
How are we doing in that race?
We're losing. I know no one wants to hear it, but we are, right? Like the variants of concern are here, right? They're anywhere from 30 to 40% of all sequenced virus in the province. So they're here and that's a problem. Whereas vaccination isn't really going to start to explode and take off until mid to late March. And we know that once you get a vaccine, you get a very, very, very good protection from a first dose of a vaccine, but that only starts about 12 to 14 days after the first dose of the vaccine. So, it's not nice to talk about, and I don't know if anyone wants to hear it, but like, if it's a race, we're not winning.
Well, this is why we're here. We need real talk like this.
Yeah, just got to call it out. You can't lie to people.
Vaccine or not, our behaviors really have to remain the same, correct?
Oh yeah, Christian, like home run. That's exactly it. Like the vaccines will help. The vaccines ultimately are going to save our butts. But the question is today or this week or for the next few weeks, they're not. We won't be able to vaccinate fast enough to keep up with this. Doesn't mean you can't keep this under control. You can. We know how to keep this under control. We've done it. We've seen it done in the rest of the world. We know what to do. And of course, we still have to pick up the pace of vaccination. It's just the pace of vaccination is not going to prevent a third wave. It's going to be behavioral interventions or non-pharmaceutical interventions, if we want to get technical with the definitions, is going to help mitigate a second wave. Vaccinations will protect the most vulnerable. Absolutely. We've got long-term care, but that's protecting the most vulnerable. That's not going to protect a wave. There's still a lot of people that don't live in long-term care that are still susceptible to this virus that can get infected.
All right, before we move into our audience questions, which there are a ton, let's take advantage of this audience that we have today. Dr. Bogoch, you're a global health specialist. Do you mind? I think it would be fascinating just to hear a bit more about the major projects you have on the go besides COVID.
Nice.
And your key fundraising priorities. Give us a little brief on that.
Thanks. I get to talk about me. Yeah, I mean, obviously, I'm a member of UHN. I'm based out of the Toronto General Hospital, and a lot of the work that I do really is involved with emerging and re-emerging infectious diseases, much like this one. And I'm not here to pat myself on the back, but the team I work with, my dear friends and colleagues, like we published the very, very first paper on COVID-19. It wasn't even called COVID-19. It came out on January 14th. And it was called Pneumonia of Unknown Etiology, the potential for dissemination from Wuhan, China through air travel. And this is what we work on.
2020, right?
Yeah. What did I say?
Well, January. I just wanted to clarify.
Oh,
so
yeah.
everyone
No.
knows
This was
we're talking
I
over
think
a
it was
year
the
ago.
first paper.
Yeah.
I think it was the first scientific paper on COVID. It wasn't even called COVID then. And again, like a lot of the work that I do with dear friends and colleagues are really focuses on predicting the spread of these infections, looking at how they spread globally, watching human mobility and looking how they spread. And quite frankly, a lot of this data that we generate and that we work on gets translated into policy, border policy at the national level, at the international level. Pretty interesting stuff. And then when I'm not there, I'm usually on site in various places in West Africa and South Asia, looking at other ways that we can prevent the spread of communicable infectious diseases, usually those that disproportionately impact the poorest of the poor, marginalized communities. So I spent a lot of time over there. Of course, COVID ruined everything, and I won't be able to travel for a little while, but all these projects are still ongoing. They're just being monitored by Skype and Zoom and email and telephone. That's often very challenging to micromanage from 10,000 miles away. But yeah, that's what I work on.
One final question to you then, in terms of the impact. Let's tie in back to the impact of the pandemic this past year. This type of work that you do, and it includes forecasting. Do it seems like it got short shrift in the public eye, certainly politically as well, over the years and decades. Do you think the pandemic has changed that? Do you think you are now seen as intertwined and essential in terms of the practice of medicine?
Yes, absolutely. Because if we think that this is just COVID-19, we'd be dead wrong. We work very closely, for example, on people might remember the Ebola virus epidemic in West Africa from 2014. And we looked at the potential for cases to land in other parts of the world. We were the very first team to look at Zika virus, and people might remember the massive Zika virus epidemic of Latin America and the Caribbean. And this, obviously, we didn't get cases in Canada that were locally acquired. We had travelers go to Zika virus endemic areas, get Zika, and bring it back to Canada. But from a Canadian standpoint, we didn't live there. But this disrupted, many of us work or travel or vacation there, and this disrupted Canadians significantly. So we were the first team to not only predict the introduction, but also to demonstrate where this was going to spread. And we've done this for innumerable other infections that people might not have ever heard of, but pose problems, mainly in developing countries, but usually of global health significance. Work very closely with partners in the World Health Organization, in various governments around the world, in various giant public health bodies to really help forecast disease spread. And it's really neat. Again, it's helpful to have several worlds collide. You've got a scientific world, a medical world, a public health world, and a policy world. And where those those circles intersect on the Venn diagram is really the sweet spot where I work. I'm biased, but it is a pretty fascinating area. And then, of course, when you've got a pandemic like this, it seems to be in high demand.
Crucial. Well, let's hope it doesn't get pushed back to the sidelines after this pandemic is over. I appreciate it. Thank you. We should get to the questions, because we've again received hundreds, and we'll do our best to get it to as many as possible. A reminder, as the live stream unfolds, our production crew behind the scenes has been busy separating out duplicate questions that were addressed in the first half of the program. Okay, first question from Gail. I should put on my reading glasses. There is now some concern about the AstraZeneca vaccine and blood clots. Denmark and Austria have suspended the use of it for now. What are your thoughts on its safety?
Great question, very timely. So, yep, we heard about this potential, we got to be careful with my words, potential association with the AstraZeneca vaccine and some blood clots. Anytime there's a potential adverse reaction to the vaccine, you got to take it seriously. You cannot sweep this under the rug. You've got to look into it further. I think it's also appropriate to put this into the much larger context. There have literally been millions and millions of doses of AstraZeneca administered in multiple countries. We have not yet heard of this. So we have to ask ourselves, this is likely related to one of three things. Number one, maybe there's an association of the vaccine with blood clots. Number two, maybe there's an association with just a batch of the vaccine and blood clots. Or number three, maybe there's no association at all, and this is true, and unrelated. Of course, you got to be careful. You got to be prudent. You got to look into this further. But it's you'll see different people look at the same data and come to different conclusions. Some places are saying, you know what, we're going to continue to vaccinate and watch it closely. Other places are saying we're going to push pause using this vaccine until we hear a little bit more. I think all are fine responses as long as you're making an informed decision. People have asked me, well, what would you do? What would you do? And my answer is, my risk threshold, my risk perception, and my risk tolerance is different than everybody else's. So what I do might not be good for you. But we sort of talked about it earlier. In the context of a pandemic with a potentially lethal infection, in the context that this is a good vaccine that has demonstrated in clinical trials and real world scenarios that it is safe and effective in preventing people from getting sick and dying, and in the context that there's been millions of doses and we're only hearing about this now in a handful of people, I would get the vaccine. That's my judgment, that's my values, and that doesn't mean that has to be your judgment and your values. But when asked, that's my opinion.
Fair enough. From Terry Lipkus.
One other point.
Go ahead.
Sorry, is like everything else. I know we sort of touched on it once. Time stamping every conversation. Look, it's 5:36 p.m. on the 11th. At 5:45 on the 11th, you might have new data. And you say, you know what? I'm going to change my mind on that, and that's fine. We should hopefully change our minds as new data emerges. But that is a 5:36 March 11th answer.
Point taken. And we do have to reiterate that because a lot of people in the general public seem to perceive that as flip-flopping, but that's science, correct?
I would say it's like, should be human nature. Like, I would hope people change their mind on anything when faced with new, your flavors of ice cream or something like that. Like when you're faced with new information, you can change your mind. You should.
Yeah. Okay. From Terry Lipkus, how high is the risk of becoming a long hauler? And are you seeing this in patients who have only had mild to moderate symptoms?
Okay, great question, because we're hearing more and more emerging data for this. Yeah, so yes, people can be long haulers, meaning your acute infection is over and you have some chronic symptoms. Usually it's fatigue, a headache, brain fog. That's usually what it entails. It's actually more rare than initially anticipated. So sometimes you hear, 50%. It's not. There's a really good study that came out 1 or 2 days ago that actually studied this pretty closely. And they looked at what, the proportion of people with symptoms. It's, when you're getting the farther and farther out you get, that those individuals with chronic symptoms get smaller and smaller and smaller. This study had about just under 3% of people who had some chronic symptoms afterwards. Now, that's still a lot of people when you factor in that, hundreds and hundreds and hundreds of thousands of Canadians have had this infection. That's still a lot of people. But on the other hand, it's not the 50 and 60% that you keep hearing in other reports as well. It looks like it's much closer to 2 to 3%. And even then, the data isn't perfect. And I suspect that this is going to be truly a real issue. We have to take it seriously. We have to treat this with an empathetic approach and learn more about it. But I think that the vast majority of people that get COVID-19 and recover, when we look at everyone who gets COVID-19 and recovers, I think the vast majority of people will not be having these issues.
Next question. With the new variants becoming more prevalent, what is the recommended protocol on washing items you buy, grocery, non-grocery, and your clothes after a shopping trip? Also on any mail or packages you receive?
Yeah, at this point in the pandemic, it's pretty clear that getting this infection by touching an inanimate object and then touching your eyes, nose, and mouth is not a major route of transmission. I mean, a year ago, we were very concerned about that. And, just to call it how it is, we were talking about masking and public masking at the time. I was very concerned that people were going to put masks on and contaminate themselves. And of course, we didn't know at the time. We were just being careful. We had no idea. And this has not borne out. Would be an extremely unusual way of getting this infection. Obviously, you got to wash your hands, but I don't think you need to wash your groceries with soap and water or really worry about contaminating inanimate objects. The real way to stop getting this is physical distancing, mask wearing indoors, and good ventilation in indoor settings. And of course, avoiding crowd, closed, confined settings.
From Claire B, once you get your first of 2 vaccine shots, are you protected enough to see family members who don't live with you and have not yet been vaccinated?
Claire B, I usually answer this by saying, I love this question, but I actually very much dislike this question because I don't have a good answer for you.
So Claire, you've stumped Dr. Bogoch.
It's not a stump. It's just like, how do you frame this?
Yeah.
What we really need is senior public health leadership in the country to come out and say, this is what's acceptable after your first shot. You know, in the US, CDC has come out with guidance for fully vaccinated people. That's people who have received 2 shots and have waited 2 weeks after their second shot. And it's very reasonable. Like in small groups, you can get together with, you know, family members or grandparents and stuff and take off your mask and not physically distance if everybody's vaccinated in that group. Like that's normal, that's reasonable. That's what we're getting vaccinated for. But, you know, what about 1 dose of a vaccine? I mean, I got to say, I think A, it would be very helpful to have some public health guidance, but B, I think in the absence of that, a lot of it will be driven by our own perceptions and threshold for risk. Nothing is going to be risk-free, but your risk is significantly reduced after one dose of the vaccine. Not only is your risk of getting the infection significantly reduced, but your risk of having if you are infected, your risk of having a severe infection is also significantly reduced. And there's great real-world data from that's emerged from Scotland, England, Israel, you name it. There's a lot of places. So some people will say, great, I'm hugging my grandkids, and that's okay. Some people are going to say, no way, I'm waiting until I get my second dose, and that's okay. I think we're going to hear some further guidance from senior leadership, but in the absence of that, I think we have to sort of look into our own individual risk calculator and act accordingly.
Good. That's good advice. I love this next question. Dr. Bogoch, what advice do you have? What would you tell your March 2020 self?
I would say pace yourself, but I'd be lying to myself. You know, in medicine, we talk about wellness. You know, it's basically a polite way of saying work-life balance. But, you know, we'd be lying if we said that there was any. Most of us are working like stink. You go to work and you work like stink. You come home and then you work like stink. I don't have a good answer for that. I would like to say something meaningful and useful, and nothing's coming to mind. I want to think about that. Maybe we'll revisit that in a few minutes.
Sure. Next question. With so many people taking immune suppressants for newly diagnosed diseases, will the vaccine and its efficacy be studied in any way? Can we feel safe?
So a couple points. One is that, you know, you hear, well, should I get this if I'm immunocompromised? Remember, the vaccines aren't going to, they're not virus. They can't activate and start replicating in you. So you don't have to be worried about that. The real concern is, are you going to get the same protection from the vaccine if you're immune suppressed? Here's how I frame it. You can either have some protection by getting the vaccine, or you can have zero protection by not getting the vaccine. Now, you can have some protection to a potentially fatal infection or no protection to a potentially fatal infection. Hey, I'm not here to impose my values on anyone else, but I'll take some protection any day, any day. And you know, now how much protection are you actually going to get? I don't know. I really don't know, because there's immunosuppression means different things to different people based on the immunosuppressants they're on. And it's a very hard thing to quantify. So I think about it in more general terms. Some is much better than none. I know there's nuance. You can't look at a crowd and say, yes, you should get it. Obviously, the details are important. You got to speak with your healthcare provider. But if you talk to for example, the transplant infectious diseases community who deal with a lot of many transplant patients at the UHN, like they're very, very vocal about promoting the vaccination and for their patient population. But again, details, nuance are important. You got to talk to your healthcare provider. But I mean, just calling how it is, there's more reasons to get the vaccine than not.
Next question. What is the latest on masking protocol? Double masking, multi-layer cloth mask, what materials, or a medical mask? Which grade level?
3 things when you think about masking. Number 1, put on a mask. Okay, step 1. I mean, it sounds so stupid, but less of an issue in Canada, more of an issue in the United States. Number 2, if you're wearing a mask, make sure you wear it properly. That means it should cover your mouth and nose. We're not at the chin masking or neck masking. It's got to cover your mouth and nose, and it should be a snug fit. This is where double masking comes into play, right? It's not because you need 2 masks. It's because you need a good fit. It's got to be snug over your mouth and your nose. Now, we heard the head of the CDC, Dr. Rochelle Walensky, say, hey, everyone calm down with these double masking things. It's only to make sure you've got a good fit over your mouth and nose. There's a million ways to do that, including double masking, if that works for you. But if you have a well-fitted mask, you don't need that. So put on a mask indoors, make sure it's got a snug fit over your mouth and nose. And the third thing is, if you should use a high quality mask. So that can be a medical grade mask, like we call them surgical masks. That could be, if you go on the Public Health Agency of Canada website, it gives you perfect instructions on what a good cloth mask is, 3 layers of the mask with tight knitted materials. So put on a mask indoors, make sure it's snug over your mouth and nose, and use a high quality mask. Simple.
Next question. There are many sources of information, and I am most interested at this point in where to go and get the most accurate and updated details related to vaccination availability for my age group, given where I live. Thank you.
Oh God, I have no idea how to answer that question.
Perhaps start with that Toronto vaccine website you mentioned earlier.
That's like if you're in Toronto, that's helpful. So really, it's going to be your local public health unit webpage would have the most relevant information for where you live. If you're in Toronto, Vaccine TO is a helpful place to sign up, but the Toronto Public Health webpage would have much better information on, who we're vaccinating at this point in time. We'll probably be in general in lockstep across the province, but it might not be in perfect sync. So it is best to reach out to the public health unit through their websites to see where they're at in the vaccine program.
Fair enough. Next question. My friend's granddaughter had to isolate due to a COVID classmate along with her sister in another school. Her father and her mother, a teacher, were told by public health that they did not have to isolate. Why would the entire family not have to isolate?
I can't speak on behalf of the public health teams, but there are different scenarios that might confer different recommendations. There's an exposure and then there's an exposure. So was this an exposure, for example, to a variant of concern, or was it perhaps a minimal exposure to a non-variant of concern? I'm only guessing here. Like, this is pure speculation on my part. So sometimes you don't need to isolate the contacts of a contact. Okay. So the family members would be the contact of a contact. Like, how far down do you go? Do you go to the contact of the contact of the contact? Like, so sometimes you don't need to, but like if it was a variant of concern, like a B117, a more transmissible variant, maybe they would isolate the contacts of the contact. I don't know the answer to this. I think it's hard to know without having more information about the case.
From Nina, Israel has vaccinated over half their population, presumably the elderly and those with risk factors. They continue to have a large number of cases and deaths. There have been 279 deaths in the last 2 weeks. How do you account for those numbers?
Yeah, I mean, listen, let's scratch the surface there and look underneath, look a little bit deeper. Okay, they have vaccinated a lot of people. Look who's getting sick and look who's dying. I'll tell you who's not getting sick and dying. It's vaccinated people aren't getting sick and dying. That's important. Then, Israel, many people on the call might know Israel or have been to Israel, have seen Israel. They have, I would say, similar, but still, it's pouring rain. They'll have similar, but perhaps slightly different issues than other parts of the world. So they have like certain sects, certain groups of the community that are not vaccinating themselves. And not only that, many of those groups are still participating in very, very large group events that would be high risk for transmission. So yeah, the numbers don't tell the whole story. And there's more context to those numbers. If you look at people who have been vaccinated, they're really, really well protected. It's not perfect, but they're really, really well protected. So I think the take-home point is get vaccinated.
From Bill, what is the accuracy of the COVID-19 quick test, and would it be appropriate to be used more frequently?
Yeah, so there's a million of these different types of tests, and some of them have varying degrees of accuracy. It's also neat, this might be a neat opportunity to talk about diagnostic testing versus public health screening testing, right? Remember, a diagnostic test is an individual goes to, thinks you might have this infection, you might have symptoms, let's go get a test. If it's positive, okay, you got COVID, sit out for 10 to 14 days. If it's negative, you're good, go on with your life. But the rapid tests aren't necessarily meant for that. Some are, but most of them, what we're talking about, are not meant for that. These are public health screening tests, and they're not perfect. They don't have the best accuracy, but the goal is, hey, here's totally asymptomatic people. Let's just call it in a factory, a place of work. Okay, people have no symptoms, but we know that some people can get COVID-19 and have no symptoms, or have no symptoms and then develop symptoms. Let's just repeatedly test a bunch of people here, even though they don't have symptoms. Let's test everyone 2 times a week or 3 times a week with these rapid tests. Guess what? Once in a while, these tests turn positive, and you say, oh, you're positive, you're positive, you're positive, you sit out. They're not the most accurate, but you can either detect, let's just say I'm just making up a number. Let's say they're 60% accurate. You can say, well, you can detect, 60 people out of a massive group of people for COVID-19, even though there was 100 there. Would you rather get 60 positive cases detected and sent home? Or would you rather detect 0 cases by not doing these tests and sending them home? So even though they might not have the same degree of accuracy, they still have a lot of utility in public health settings by creating safer indoor spaces. I'm not sure if I explained that right, but
it's helpful. I think it's helping us understand between the difference between like the gold standard test and the value of having these quick tests as a screening tool.
They're really important, and they're underutilized in Canadian settings. And I think you're going to start to see these things ramp up massively in businesses. Here's what's another interesting thing, just sort of related to this. The business community recognized the utility of these tests really early on. And while we, the medical and public health and scientific community, were futzing around and thinking, well, it's not as accurate, and how do we reconcile this, and how do we use them? They didn't care. They just bought a bunch of tests and started integrating them into their businesses. And kudos to them, because they've done it very successfully in many parts of Ontario and Canada. They just did this, and they did it well, and they created much safer indoor spaces. So, like, credit where credit's due.
Is it reasonable to assume that our healthcare system now has measures in place to ensure that we are never hit this hard by a pandemic again? Would love to understand some of your big learnings as an IPAC doc.
Yeah, I mean, I'm not an IPAC doc for starters, but I am an infectious diseases physician. There's a slight difference. And for years before this pandemic, this is what I do. I work at there's the clinical work in infectious diseases and tropical diseases, but the research is really on the global spread and emergence of epidemics and emerging infectious diseases and how they spread around the world. So, when this pandemic is over, we're going to need to sit down and think about how we can be more prepared for the next one. And when we do that, I think all we'll need to do is take the SARS write-up from 2000 and I forget, it was a year or two after SARS. Well, SARS was 2003, 2004, but there's the SARS Commission, which came out a year or two later. And all we have to do is go dust, cross off SARS and write COVID-19. Because you don't need to reinvent the wheel. It talks about everything that you need to talk about. It talks about local production of PPE, local production of vaccines. It talks about the precautionary principle. It talks about masking. It talks about all these issues that we're talking about now that, we didn't forget. We know it. No one forgot it. It just wasn't kept up. It wasn't implemented. It wasn't kept a priority. Now imagine you're a government. It might be expensive to maintain certain things. It might be expensive to fund those programs. And why would you pour money into something that might never happen? Well, it does happen, right? We've had SARS, we've had Zika, we've had H1N1, we've had chikungunya, which people don't know, but it's all through Latin America and the Caribbean, and it's nasty. We've had MERS that hasn't really landed in Canada, but it has landed in many other parts of the world. We've had this, that's in a short period of time. This is happening. This will happen again. You got to be prepared. And I mean, I'm not trying to do this, but there is a group of us who are in, you could call it different things: health security, global health security, emerging and re-emerging infectious diseases, you name it. We have our conferences. We know about this. We talk about this. This is all we think about and all we do. Now it's obviously our heyday, but I hope this doesn't get forgotten, because we certainly need better processes in Canada, but also better processes globally. So it is important. We can't forget about this.
Agreed. This may have to be our last question, Dr. Bogoch. In the 75 to 79-year-old seniors, are all these ages lumped together, or do they start with 79-year-olds first, then 78, then 77, et cetera? Haven't seen this addressed anywhere.
5-year increments, 5-year increments. So 80 plus, 75 to 80, 70 to 75, 65 to 70. It's going to go in 5-year increments.
All right. Listen, this was quick today. We got to thank you again for taking the time to be here. But we've got to come to a stop. I want to thank you, Dr. Isa Bogoch, UHN staff physician in the divisions of internal medicine. Thank you so much for taking out the time of your busy day to share your insights. As always, this live stream will be available on the Foundation YouTube page. And we have a new initiative to tell you about today. It's called, and I have to be careful with this, Give a Shift. If you have been moved by the amazing work of our healthcare workers at UHN, you can now show them through Give a Shift. Give a Shift is, they make me say this so many times, is a first of its kind fundraising event to honor our healthcare heroes and raise funds for UHN. To learn more, go to giveashift, that's all one word, .ca. Finally, donor support. It plays a critical role in helping Team UHN on the front lines as they care for and treat COVID patients. As well, donor dollars fuel the research of people like Dr. Bogoch and the hundreds of scientists working to improve and discover new treatments for this deadly virus of coronavirus. So if you're able to give, we ask you to consider making a donation. Go to www.tgwhf, that's tgwhf.ca/help. Thanks for tuning in, everyone. We'll be back next month with another episode, so keep an eye on your email inbox. In the meantime, I'm sure Dr. Bogoch would join me in saying, keep practicing physical distancing, wash your hands often, and mask up. Stay safe, everyone.